All right. Well, good morning, everyone. And we have yet another exciting installation of NB Heart Center CV Weekly Rounds. And this morning, we have a special guest from our Department of Diagnostic Imaging at the St. John Regional Hospital, Dr. Matt Bligh. Matt's joined the group and has been an invaluable asset to the cardiac world here. Just by way of background, Matt's done his med school in Halifax and also did his radiology and his nuclear medicine residency at Dal, but then he went on to Harvard and more specifically the Beth Israel Deaconess and did his fellowship in abdominal imaging with additional training in cardiac imaging. So it's with that he has come back and from our standpoint really has provided MR at a high level for cardiac disease workup. And when I originally approached him, I wanted to talk about a lot of different things that MR could be helpful for in the cardiac world. And he quickly stated that that was too much for this particular 20-minute talk. So we thought we'd break it up into 2 or 3 talks. And this specifically was looking at MR imaging and nuclear imaging in infiltrative cardiomyopathy. So I thought that would be a great start. And then we can talk about other stuff down the road, like heart failure, et cetera. So without further ado, Dr. Matt Bligh.
Thanks a lot, Ansar. So yeah, I thought I would talk about MR and nuclear imaging strategies for infiltrative diseases, and particularly sarcoid and amyloid. So I'm just going to jump right in. Sarcoid is a multi-system granulomatous disease. It's actually fairly common. It's most often involves thoracic lymph nodes and lung, and then beyond that, various other organs, including the heart. Cardiac involvement is actually not that uncommon. It's found in 25% or more on autopsy. And then only about 5% of patients with sarcoid have clinically apparent cardiac involvement though. It does cause a disproportionate number of deaths because of its propensity to cause severe heart block and arrhythmia. But patients do often have a non-specific presentation with palpitations and presyncope and things like that. So there are a number of different diagnostic criteria used, but the most common in current use is the Japanese Circulation Society, which came out in 2016. So that's a combination of clinical and imaging and biopsy criteria that allow a diagnosis potentially without biopsy in certain scenarios, and it can also allow you to recognize isolated cardiac sarcoid, which is actually quite a bit more common than was once thought. It's actually about 25 to 30% of cases overall. And so biopsy is an option, but it's usually not done because it's relatively insensitive, just due to the patchy kind of infiltrative nature of the disease. Sampling error is the issue with that. So echo is used as a first-line imaging modality. Sorry. But echo is actually normal in most cases. So that's where CMR and nuclear imaging come in. So with MRI, we perform MR using functional imaging with volume quantitation, and then we do T2 weighted imaging, which detects edema and also characterizes infiltrative diseases and tissue abnormalities. And then we also use the mainstay of sarcoid imaging is post-gadolinium, late gadolinium enhancement. And that detects both inflammation and chronic inactive fibrosis. So there are also some emerging techniques that we use, namely T1 and T2 mapping that are coming, and they were kind of more of a research thing, but they're becoming more prevalent in routine practice, and we should be starting to do that here relatively soon. We're just waiting for a software upgrade. So MRI, the main role of MRI in sarcoid is initial detection and characterization of disease. So MR is by far the most sensitive modality. It can detect very small abnormalities that wouldn't be picked up on other imaging, and it gives you an excellent overview of disease distribution throughout the heart. So it uses late gadolinium enhancement. And just to really briefly cover that, it's we inject the patients with gadolinium contrast, and then we wait at least 10 minutes and allow the contrast to distribute to the tissues. It perfuses through normal tissues, and a lot of it washes out by about 10 minutes. And then what's left is abnormal retention of contrast in abnormal tissues with increased extracellular volume. So that can include inflammation and scarring. And cardiac MR in that sense is also useful as a risk stratifier, because it's been shown in a number of studies that having absence of late gadolinium enhancement or LGE with a good quality MR portends a low risk of events, whereas having a positive scan correlates with a significantly increased of adverse events. So so it's very useful in that sense. And occasionally you would have a false negative study, and that would occur in patients who have very early inflammation that hasn't had sufficient time to generate enough increased extracellular volume that it would show up as gadolinium enhancement. And with those cases, they can often be detected with PET. So typical findings we see in cardiac sarcoid are usually decreased global LV systolic function, plus or minus focal wall motion abnormalities, and sometimes wall thinning. And the distribution of enhancement tends to be basal predominant. You can have basically anywhere in the heart, but it tends to be in the base of the left ventricle most commonly. Usually spares the apex, and then sometimes you do have other chamber involvement as well, and even valves and pericardium can be involved too. So the distribution of enhancement is quite different than a ischemic scar. It tends to be kind of patchy mid-wall to subepicardial distribution, sometimes transmural, and it can also be subendocardial, and it can mimic ischemic disease as well, but it's usually it's not going to conform to a vascular territory. So so PET is quite different. So this is a nuclear technique that uses FDG, which is radio labeled with fluorine 18. So that's a artificial radio tracer, and that FDG acts like a glucose analog in most ways. So basically, we inject the patients and wait an hour and let the stuff distribute through the body, and what we end up with is a map of metabolism. So areas of increased uptake show areas of increased metabolism. And so we also we typically perform a full body scan, and then for cardiac imaging, we do a high resolution capture of the heart. And we also do a CT, a low dose CT for correlation and attenuation correction through the whole volume. So this study is also done with a routine resting SPECT myocardial perfusion scan for correlation as well, and that's important in the interpretation. So one thing I just wanted to point out is that the preparation for this is very different than an oncology scan. If you look at an oncology PET scan, you may see patchy or complete diffuse uptake throughout the heart, and that would be normal, just where the myocardium is using glucose metabolism. But in order to reduce that, in this case, we want to switch the heart to fatty acid metabolism. So we put the patients on a low carb, high fat diet for 24 hours, and then they go through a period of fasting before the scan. So that just suppresses the normal background. So PET is, some people like to compare it to MRI in terms of its accuracy, but it's really a complementary test. It shows a different aspect of the disease, and it often will identify additional sites of disease. And it also it's good for detecting extracardiac disease as well. So patients who have clinically unsuspected extracardiac sarcoid will often have findings on PET, which can then further support a diagnosis of sarcoid. And it also assesses disease activity. So the key difference between this and MRI is that with MR, we're imaging both scar and active inflammation. And with PET, we're really just looking at the active inflammation. So we can distinguish between those two things, whereas with MRI, we can't really reliably distinguish. So that makes PET very useful for monitoring of patients who are on immunosuppressive therapy to see which direction the therapy is going and whether or not it needs to be changed, or whether it could be tapered or stopped. So it's used in serial monitoring, and it's quite accurate for that. So generally similar to LGE, presence of FDG uptake increases your risk of having adverse events. So we have, between the perfusion scan and the PET scan, there are a number of combinations you can have, which generally indicate the stage of disease you have. So if you had a really early lesion, you may have elevated metabolism with preserved perfusion, and then that would generally progress to a perfusion defect. And finally, with inactive disease, you generally will have a perfusion defect without abnormal metabolism. So in terms of therapy monitoring, we often see a pretty dramatic response with steroids. Like this is a patient who went on steroids for a few months and had extensive disease in the chest and the heart at baseline, and then had complete resolution after a few months of steroids. So if we were to take this person and do 2 MRI studies, we'd probably see a pretty much stable distribution of disease, but we wouldn't be able to tell if it was active or not. So that's the advantage of PET here. So here's just another example case. This is a 66-year-old male who came in with an undifferentiated cardiomyopathy. Sarcoid was in the differential. So this is an MRI study. So you can see there's pretty extensive hilar and mediastinal lymphadenopathy here. And then if we look at our short axis T2 weighted images, you see there's edema in the basal anterior septum and anterior wall, and then also in the infralateral wall. So then moving on to the post-gadolinium images. These are the late gadolinium enhanced images. So you have 4-chamber view and short axis view here. So you can see there's really extensive patchy bright signal all through the heart, including the atrial septum, right ventricle, and most extensive around the base. So here you can see that there's really almost transmural involvement through the basal segments. So this person went on to have a PET scan 2 weeks later, and you can see there's pretty intense uptake in a similar distribution. Although there are some minor differences between the two, and that's like what I was saying, they can kind of identify different components of the disease. And then you also see intense nodal uptake as well. And all this renal uptake is just normal physiologic excretion. So this person went on and had a follow-up PET after 5 months of prednisone, and you can see that the activity is completely resolved. So there's no more active inflammation. Although again, if we were to do MR, we'd probably see a similar extensive distribution of disease. And this person also had a significant improvement in the LVEF from 33 to 53% over that time period. And that functional improvement tends to follow with resolving inflammation. So what I would suggest, generally speaking, as an imaging strategy is starting with MRI to detect and characterize sarcoid. And then if the MRI is positive, in most cases, a PET would be indicated to determine the disease activity and identify additional sites. And in some cases, if the MR is negative and there remains high clinical suspicion, it's usually also worth doing a PET scan, because it can sometimes detect that early disease that doesn't show up on MRI. So if there's high suspicion, I would usually proceed to PET. Whereas if it was more of an undifferentiated cardiomyopathy and there was nothing on CMR, then you can probably get away with not doing PET in those cases, because the yield is generally quite low unless clinical suspicion pretest probability is high. So moving right on to amyloid. So this is another multi-system disorder involving protein deposition in the interstitial tissues. And there's really 2 major types. First is light chain, and that was once thought to be more common, although it's quite rare. And that's where you have immunoglobulin light chains, which are abnormally folded and just deposit and persist in various tissues, including the heart. And the other is transthyretin, which is actually much more common. And that's a transport protein involved with thyroid hormone. And so the 2 main types there are wild type and hereditary. So with wild type, it's associated with age-related misfolding of proteins, resulting in this insoluble infiltrative disease. And then there is a small minority, about 3 to 5% of those patients have a mutant type, which is hereditary. So that warrants some genetic testing. So in any cases of amyloid, cardiac involvement is the driver of prognosis because of the severe cardiomyopathy that it causes. And it accumulates in the myocardium in the interstitium and then causes diastolic dysfunction and eventually restrictive cardiomyopathy. And then that eventually progresses to dilation and systolic dysfunction in the later stages. So I'd like to focus on wild type TTR because that's actually what we see most commonly. And so that actually is most often only limited to the heart. It doesn't tend to involve other tissues throughout the body, except in some cases, some connective tissue involvement. It often presents with carpal tunnel as well. And this has a much better survival than light chain amyloid at 6 years from the onset of heart failure versus 6 months. So that makes it important to distinguish those two. And it tends to be underdiagnosed, even though now people are more aware of it because it's just so common. It's recognized, especially in older patients, males more than females, in patients with severe aortic stenosis. And in some series, there's been several series done of this, and it usually comes out to between 10 and 16% who are found to have TTR amyloid along with severe AS. And it tends to be the low flow, low gradient type who have it for whatever reason. So diagnosis-wise, echo is typically first line, and echo can show some highly suggestive findings of amyloid, although non-specific. And so then the next step is typically CMR, which can show some additional high specificity findings, and it's also quite sensitive for both types of amyloid. So if CMR findings are suspicious, then the next step would be moving on to potentially genetic testing and light chain assays and things like that, as well as technetium PYP scans, which is type of bone scan, which we'll talk about in a bit. And in some cases, myocardial biopsy would be required for final diagnosis. So in MRI, the main role is to confirm a diagnosis of amyloid. It doesn't tend to differentiate very well between the subtypes of amyloid, although you do see there are some features of each that can suggest one or the other, but it's similarly accurate for both. So we use it as more of a disease detection and characterization. And the other important thing with CMR is that it can identify other causes of cardiomyopathy that may present similar to amyloid. So that's one of the key things as well. The typical findings that we see in MR are diffuse wall thickening, and that often involves multiple chambers, not just the left ventricle. Sometimes you can see just regional thickening, often involving the septum. Usually has preserved EF in small chamber volumes until late stages of disease, and then it becomes dilated. The enhancement patterns are helpful in most cases. So there's a few classic enhancement patterns. One is this diffuse subendocardial pattern where you have just subendocardial enhancement throughout the whole left ventricle and sometimes right as well. And then the other is this diffuse complete abnormal enhancement throughout the entire myocardium. And that can actually create problems for us when we go to do our background suppression for our late gadolinium imaging. So sometimes when you have technical problems with that, amyloid would be a suspicion because the whole myocardium is abnormal, so you can't suppress the normal background because there just is no normal background. So similar to sarcoid, native T1 and T2 mapping are up and coming, and those are becoming more common, and it's starting to be recognized that they can detect disease in some cases more accurately and earlier than other techniques. So CMR, if CMR findings are positive or suspicious, then it's best to go on to other imaging and labs to confirm diagnosis and distinguish between the subtypes. So in our case, in North America, we use PYP or pyrophosphate scans with technetium as a tracer. This is a single photon tracer, so we do planar and SPECT CT imaging rather than PET. And the uptake, for some reason, this does show highly avid uptake in TTR. And it's thought that that's related to calcium phosphate binding of the abnormal protein fibrils. But it's important to note that it does occasionally have some degree of uptake in light chain amyloid, although it's typically much less. So you can occasionally get equivocal scans with light chain amyloid. It's very high sensitivity, and the specificity is also fairly high, but its limitation is confounding with light chain. So that being said, it's still a very useful test because we can clarify with labs which subtype we have. So there are a number of different ways of doing this. Most places do planar and SPECT CT imaging. There are some guidelines suggesting using ratios of the heart to contralateral lung, so you can kind of compare the uptake in the heart to the opposite side of the chest on planar images. And we've found, and similar to our colleagues in Halifax, that SPECT CT is much more reliable for this because we tend to have a lot of blood pool activity that gets confounded as cardiac uptake on planar imaging. So we use SPECT CT and rely more so on that. So where this comes into play is once patients have a high suspicion based on imaging and clinical findings, you can use this to differentiate between TTR and light chain. So if this is a positive scan, there's a very high likelihood that this will be ATTR. And to finally distinguish between those two, if you can confirm absence of a plasma cell clonal proliferation of light chains, then you have a diagnosis of TTR without needing biopsy. So that's the goal here. And there's really not much else that causes intense uptake like this throughout the heart. So one thing I wanted to point out is that this does not currently have any role in monitoring patients on therapy for TTR. It doesn't show changes that reliably coincide with clinical improvement. So we don't use it for that purpose. So here's just a couple of example scans. So this is a normal scan. So you can see on the top images, the planar images, that this is basically just a bone scan, and you might have a little bit of faint uptake in the left chest here, which corresponds to the heart. So if we did our ratios on that, it might come out equivocal. But if we look at the SPECT CT, this is an axial image of the heart. You can see that this is actually all blood pool activity. And really on the SPECT CT, you can see there's really nothing in the myocardium itself. So this would be a normal scan graded as a 0. And on the other hand, here's a positive scan. So in this case, you have diffuse intense uptake throughout the whole left ventricle, and also some degree in the right ventricle and atrium as well. So this is a positive scan, or grade 3. So this would be somebody with TTR. Okay, and that's basically all I had. So the key things just to emphasize are that in sarcoid, CMR and PET are really complementary modalities, and in most cases they're both useful, especially in initial staging of disease. LGE and FDG uptake in the context of suspected cardiac sarcoid do correlate with an increased adverse event rate due to higher rates of ventricular arrhythmias. And then PET is the one that we use for monitoring. So there's really not much of a role for MR in therapeutic monitoring, whereas PET is used routinely. And for amyloid, MRI is used to identify and confirm amyloid as a diagnosis over other infiltrative diseases, but it doesn't tend to distinguish AL from ATTR. So that's where nuclear scans come in, and using nuclear scans plus light chain assays, we can arrive at a diagnosis of TTR, which is increasingly recognized as being a very common disease. So that's all I have.
Very good, Matt. Thank you. Great overview of MR and infiltrative disease, and specifically with respect to sarcoid and amyloid. Dave Buick, I think you had a question.
Yeah, no, Matt, superb overview. Really enjoyed it. Nice, concise argument for CMR. So I have 3 comments. Maybe you could just kind of answer them in less than a minute. So the one question I have is, we see a young patient, 50-year-old, complete heart block, and they need a pacemaker. So they may or get a pacemaker. We try to rule out, I mean, we should think of sarcoid. If they get a device, say a pacemaker, how can we do a CMR after a device, ICD or pacemaker? That's question 1. Question 2 was, I disagree with your algorithm. You can give me your counter argument about if it's TTR, I wouldn't go to CMR, I go to PYP first. If your PYP is positive, then CMR really adds no value. If your PYP is entirely negative, then it really excludes TTR. So I just wonder about switching your algorithm around to going directly to PYPs for CMR. Yeah. And what do you do with the PYP that's equivocal? It drives me crazy, because when equivocal, does that mean they could have? So those 3, CMR or MRI with a device, how accurate is it for picking up sarcoid? The 2 is the algorithm, the 3 is the equivocal scan.
Okay, yeah, so the first question, how accurate is MR once they have a pacemaker? Well, I find that ICDs and pacemakers don't really interfere much with our imaging, to be honest. The artifact from those is pretty minimal, and it's usually localized to the RV. It doesn't tend to interfere much with the myocardium, with visualizing the myocardium. So I don't find it to be a major problem usually. And okay. So I think if you had a patient, I wouldn't wait to put an ICD in just for the purposes of MR, although I think there's a waiting period after where they can.
But you know how the radiologists get when you say someone's got a can in their chest and you want to send them for MR. Well,
yeah, it's a bit more complicated to book them, I guess. There's more coordination involved, but in terms of imaging quality itself, I don't think that it significantly degrades the quality enough that it would affect our interpretation in most cases.
Yeah, I guess I was getting at some radiologists are really adamant they will not do an MR if they have any metal in their chest.
Yeah, we shouldn't. well, the only reason that should be an issue is if there's an incompatible or non-MR conditional pacemaker. Otherwise, it would just be a matter of confirming and updating our department guidelines. So I don't, that shouldn't be happening here. I don't know.
Okay, that's good to know. Yep, because otherwise, you can wait a week and you got someone complete heart block.
Well, yeah,
sitting
exactly.
on CCU. Well, why not just go put a pacemaker, because they still need the pacemaker.
Yeah.
So that's good to know.
But I think,
What about, yeah,
as far as
so
I
the other
understand,
two-
there is a waiting period. So after they have a pacemaker, they can't undergo
Yeah.
MR for a certain number of weeks, right?
Yeah.
So, and then your second point around the algorithm of when to do MR versus PYP, you have a good point, and that's correct. That if you have somebody that you're pretty confident has amyloid, you could skip MR in that case because it's not likely to add further to your diagnosis. It's more so the patients who have kind of questionable findings and they may have some other infiltrative disease, or if you just want to get or if you just want to get an overall evaluation of the extent of disease, then MR is better. But yeah, you're right. Like, and here we actually do most of our PYP scans, including our positive scans, are in people who don't have MR. So I think that we don't usually do MR here as much. So that's really an option, but it's helpful in the ones you want to differentiate or evaluate extent of disease. So I think the published guidelines do use MR as kind of a primary modality, and then PYP as part of the further workup. But yeah, that's a good point. You could avoid MR in a lot of cases.
And the last one's the equivocal PYP.
Yeah, so those are there is an diagnostic algorithm where those come into play. So those are ones where basically you would have, that would be showing evidence of some type of amyloid, but then you would have to go on and distinguish that from between TTR and light chain amyloid. So doing that plus light chain assays and other labs would help you to distinguish. The other thing would be the equivocal scans can be due to artifact. So so you could, I mean, potentially you could repeat the study if we look at it and think that the parameters used are inadequate. Like, for example, if the patient has advanced renal failure and there's a lot of intense blood pool activity that could be masking or producing a false positive, the study could potentially be repeated. But equivocal results are just part of the spectrum that we see in this imaging. So there are published guidelines on how to proceed with those patients. But yeah, that's the thing. It's not as specific for TTR in those cases.
Thanks, David.
Okay.
Thanks, Matt. And quick question from JF before we close up.
Thank you, Matt. This was very good. Just my general thought is that I think we underutilize MR screening, and if you were to comment on what our capacity is here in St. John and how you would best suggest we would utilize.
Yeah, well, we've increased the number of scans we can do by cutting the time of imaging down to some degree with using more updated sequences. So right now our general capacity is routinely we do 3 patients per week. We sometimes will do 4 or 5 depending on demand if there are urgent inpatients. It'd be nice to get more time. I guess something to point out is that we actually have excellent MR wait times generally in St. John. We've been able to tackle the COVID backlog quite well. So I think with those wait times coming down and now being within national guidelines, I think we should be able to get more capacity for cardiac MR. So I'd like to see us be able to do routinely 5 or 6 patients per week. And for context, a couple of years ago, we were doing 2 per week. So now we're probably close to double that capacity at this point. There are also newer sequences coming through regularly that enable faster imaging, so we can further decrease the imaging time, and we're gradually doing that. So yeah, I think there are a lot of indications for MR that are underutilized, but I mean, part of it is capacity and how long you're willing to wait. But I think that has been improving a lot lately. So I hope that we'll have further increase in capacity over the next year or 2.
So if we order more, will we do more, get more done? I think all of us would order more if we felt it would be getting done.
Yeah, I mean, I think that we're getting them done faster now, as far as I know. And I think a lot of the backlog has cleared. So yeah, I mean, if there's more demand, we can make a case for more magnet time. So yeah, I mean, we can kind of work with that. If the demand were to go up a lot, then the wait times would naturally go up, but we can also then work to get more time for cardiac MRI, and there are ways we can do that. So yeah, it depends on demand.
Matt, thank you so much. This is great, and looking forward to install number 2 sometime in the fall. But this was a great overview, and I'm not going to lie, I'm going to have to review this talk later tonight when I'm posting it on YouTube.
Yeah, it was a lot of.
Yeah, there was a lot of good stuff in there, and I think but I love your summary slide, and I think that's a good take home right there. Awesome. Thank you so much. Thank you for your time, and thank you everyone for joining. Next week, our cardiac anesthesia group is going to be contributing a talk looking at sedation, and specifically sedation in the setting of cardiac procedures. So looking forward to that with Dr. Ashley O'Brien. All right, everyone, have a great day, and we'll see you next week.
Thanks very much, Answer.
Thank you, Matt.